Hello, ladies and gentlemen. It is my pleasure to welcome you all to this academic session. I'm Dr. Maitri Shankar from Institute of Nephrology, Bengaluru. I'm also the Secretary of Women in Nephrology India, Karnataka chapter. Win India has been spreading its wings, as you all know, and Win India Karnataka state chapter was inaugurated in November 2022. Formed under the aegis of Win India, the Karnataka state chapter aims to embolden the core values of women in a nephrology group at a regional level. We are delighted to have you all join us at the 5th academic session of the Women in Nephrology India Karnataka chapter. It gives me immense pleasure to host today's session, and it is indeed an amazing honor to have wonderful Dr. Sylvie Shah from USA to provide her insights on contraception in patients with chronic kidney disease, which is considered most of the time as a taboo, and most of us don't even discuss this with our patients in our regular OPDs. Followed by this, we have original research presentation by Dr. Pooja Prabhu. She has done an extremely wonderful work on cystatin C and pregnancy. And following that, we'll have from our amazing Dr. Gyanapriya. She's our nepropathologist in St. John's Medical College. So she'll be giving us an introduction to kidney biopsy. My heartfelt thanks to all the speakers and chairpersons for sharing their valuable time with us today. And it's time for us to start today's session. Dr. Renuka ma'am is the president of Women in Nephrology India Karnataka chapter. She's traveling today and she has sent her best wishes to all of us. I invite the chairpersons for our first session, Dr. Anupama YJ, consultant nephrologist, Nanjappa Hospital, Shimoga. Dr. Anita, consultant nephrologist, Apollo Hospital, Bangalore. Dr. Shakuntala Modi, consultant nephrologist, NU Hospital, Bangalore. A warm welcome to all our chairpersons. I request our chairperson to introduce our main speaker for tonight, Dr. Sylvie Shah.
Thank you, Maitri. It's an immense pleasure to be here chairing this important session. We all are aware that this is quite a neglected topic in our day-to-day clinical practice. Though we see so many women with CKD, we hardly discuss the reproductive options or how they have to plan their family, how to plan the contraception. This has such an important bearing on their clinical outcomes. So to discuss this with us, we have Dr. Sylvie Shah, who is a physician scientist in the University of Cincinnati, USA. She is an acclaimed specialist in reproductive medicine and nephrology. She has a special interest in that area. And she has more than 60 peer-reviewed articles, and she's on the editorial board of important journals like JASN and CJASN. It's my pleasure to be welcoming you today, Dr. Sylvie Shah. We are all eager to listen to you.
So thank you, Dr. Anupama, for the wonderful introduction. Thank you, Dr. Maitri Shankar, for inviting me, and Women in Nephrology Karnataka chapter for having me. So let me start share screen. So I would be talking about balancing reproductive health and kidney disease, navigating family planning and contraception for patients. I have no disclosures. And these are the learning objectives. We will discuss the impact of kidney disease on fertility and pregnancy outcomes, then briefly talk about pregnancy risk assessment and counseling, and then in the end, summarize contraception and family planning for our patients with kidney disease. So let's start with the case. I have a 32-year-old female with history of kidney failure who is undergoing hemodialysis due to lupus nephritis. She sees me in the clinic and wants to have a baby. She is currently on lisinopril, labetalol, and vitamin D, and she has these following questions. What is the likelihood of pregnancy? What is the likelihood of pregnancy complications? Should I use contraception if I decide to wait? And which is the best contraception to use? So what happens with chronic kidney disease? So there is disruption of hypothalamic gonadal axis, which occurs with progression of kidney disease. And as we can see in this figure, there is decrease in the levels of estrogen, progesterone, and testosterone. And there is increase in the levels of prolactin and luteinizing hormone, which is ultimately responsible for loss in the surge of luteinizing hormone, resulting into anovulation and infertility. So in the past, it was believed that women on dialysis cannot get pregnant, and previous studies showed a very low conception rate for women who were on dialysis. However, this was one of the first studies which our group published, which looked at pregnancy rate for women with end-stage kidney disease on dialysis. And we had around 50,000 women in the cohort. We looked over a period of 8 years, and we reported around 2,300 pregnancies with a pregnancy rate of 18 per 1,000 person years. And this was actually the first time it was reported in literature, such a high rate of pregnancy for women undergoing dialysis. One of the advantages of our study was that we were able to capture all women in the United States who were on dialysis because we used claims data, and we were able to capture all pregnancies which occurred. So the study reflected accurate rates. We also found like cause of kidney failure or end-stage kidney disease had a impact on the pregnancy rate. The women whose kidney failure was due to malignancy or glomerulonephritis or hypertension had higher rate of pregnancy as compared to women whose cause of kidney failure was due to diabetes. And dialysis modality again had an impact. So women on peritoneal dialysis had a 50% lower chance of conceiving as compared to women on hemodialysis. And again, we don't know the real reason for that. The hypothesis is that on peritoneal dialysis, because of hypertonic dextrose solution, there could be impairment in the implantation of ovum, which occurs, which may be responsible for lower pregnancy rates. So what happens with kidney transplant? So gonadal function resolves by 6 months post-transplant with return in fertility, and menstrual cycles resume within 2 months. And therefore, it is very important for us to start counseling our patients about family planning and contraception. And this should start right at the time of transplant evaluation, even before they get a transplant, because all the women of childbearing age would have to be on some sort of contraception after they get a kidney transplant. And several reasons are responsible for that. One of the reasons is that majority of these women would be on mycophenolate, which is teratogenic. So we want to make sure that they don't get any unintentional pregnancies or any pregnancies while they're on these teratogenic medications. So the next question our group had was, what is the rate of pregnancy for women in kidney transplant? And we did show that women on dialysis had a rate of 18 per 1,000 person years. And when we looked for pregnancy rate in kidney transplant, it was in fact lower. It was 14 per 1,000 person years. And one of the reason for this could be, again, that most of the pregnancies for women with kidney transplant are planned. All women with kidney transplant are followed in a multidisciplinary manner. They see, and that is why they receive better counseling. They may be receiving better family planning options. And most of these pregnancies, therefore, occur in a planned manner. And that could be one of the reasons why we found a lower rate for pregnancy for women with kidney transplant as compared to women who were undergoing dialysis. Also, we noticed that there were higher rates in younger women, which is expected. And there was also higher rate in second and third year post-transplant as compared to first year post-transplant. And this, again, could be related to the reason that most of the guidelines suggest that women with kidney transplant should wait for at least 1 year before they decide to get pregnant. Why it is important for us to talk about pregnancy with kidney disease. And one of the reasons is that all pregnancies, either with chronic kidney disease, with dialysis, or with kidney transplant, are higher risk pregnancies because it's associated with higher risk of adverse outcomes. So there's high risk of preterm birth, there's high risk of low birth weight, restricted growth of fetus, perinatal mortality. At the same time, there is high risk of adverse maternal complications, including worsening of kidney function, preeclampsia, and cesarean section. So one of the questions which I'm often asked is, what would happen to my kidney function if if I decide to get pregnant with kidney disease? And we don't have a lot of data on it. This is one of the very few prospective studies, which again has been done 3 decades back, which looked at the decline in kidney function with pregnancy and chronic kidney disease. And they divided women into 3 categories based on their preconception creatinine and followed their creatinine over the course of their pregnancy till 12 months postpartum. So as we can see in the top panel, when women had preconception creatinine of less than 2, around only 1%, which is needed dialysis by 12 months postpartum. So these dashed lines represents progression of their kidney disease needing dialysis. However, if women had creatinine of 2 or more, around 30% of them needed dialysis by 12 months postpartum. So this is a number which I tell my patients that if your creatinine is 2 or higher to start with, you will have a 30% chance of needing dialysis by 12 months postpartum. And the other important thing which, I counsel my patients as well is that the stage of chronic kidney disease makes a difference in the risk of adverse outcomes. So the higher the stage of chronic kidney diseases, the higher is the risk of adverse outcomes. And this again is the data showing the adverse outcomes were divided by stages of chronic kidney disease. So this is by Dr. Braham and group from UK, and on the right panel is the data from Dr. Piccoli and group from Italy. And they looked at various pregnancy outcomes and divided them by 5 stages of chronic kidney disease. The lighter bar represents stages 4 and 5, which is at the bottom. And as we can see, for stages 4 and 5, the risk of adverse outcomes was the highest for all the outcomes. So for the risk of preeclampsia, the risk was about 60% with stage 4 and 5. With regards to preterm birth, the risk was up to 90% with chronic kidney disease stage 4 and 5. And there again was a 70% risk of 25% reduction in GFR at 6 months postpartum. So what happens for pregnancy outcomes and kidney transplant? So pregnancy, as we did discuss briefly, the pregnancy, the risk of with kidney transplant, there's return of fertility. And the other thing is the outcomes are much better with kidney transplant if women do not have risk factors to start with, which is defined by a stable creatinine of less than 1.4, well-controlled blood pressure, optimal immunosuppression, and no recent episodes of rejection. And this again is the data showing the various pregnancy outcomes from 3 of the largest studies. So this is the Transplant Pregnancy Registry, which is in Philadelphia in the United States, which is a voluntary registry which collects information on pregnancy outcomes with solid organ transplants. This is a meta-analysis from Dr. Deshpande and group, where they looked over a period of 20 years for various pregnancy outcomes with kidney transplant. And this is the data by our group where we looked for over a period of 50 years, we looked at all the studies which reported outcomes with kidney transplant and then compared it to US general population. And as we can see, the rate of live births is actually better with kidney transplant. So it's more than 70%. It's much better than even the general population, indicating that there's a selection bias for these patients. So most of the women who decide to get pregnant with kidney transplant are overall healthier. They have less risk factors, and that is why the live birth rate is better even than the general population. The risk of miscarriages is comparable to the general population. We did see a slightly higher risk of neonatal deaths and stillbirths, and that is what we counsel our patients as well. There is also a higher risk of preeclampsia, cesarean section, preterm births, lower birth weights, and that is what we tell our patients as well. And that is why, again, it is very important that all our patients with kidney disease or kidney transplant deliver in a tertiary care center where they have access to neonatal services, because most of the babies who are born would be preterm and will have low birth weight. The other question I'm often asked is, what is the risk of rejection and what is the risk of graft loss? Now, we don't have a lot of data for it, but whatever studies have shown is that the risk of rejection and the risk of graft loss is comparable to the non-pregnant transplant population. But again, we have to keep in mind we have to make sure that all these pregnancies are overall with minimal risk factors, that they have creatinine of less than 1.4, blood pressure is well controlled, and they're on optimal immunosuppression. And that is what we counsel our patients as well. So we did discuss briefly that we did find a very high rate of pregnancy for women on dialysis, and that rate was higher than pregnancy rate for women with kidney transplants. So our next question was like, why this rate is higher? And our hypothesis was that most of the pregnancies for women on dialysis are unplanned. And that is why we wanted to look at the contraceptive rate, that what is the rate of contraceptive use for females on dialysis. And actually, our study was the first one to report a rate of contraception use for females on dialysis, and it was 5.3%, which is much, much lower than the overall general population rate, which is around 60% in the United States. And we did find that IUDs and pills were the highest, the top most types of contraception which were used by these women. Our study did have the limitation that we were not able to capture barrier methods. We were not able to capture the male contraceptive methods. So it did have those limitations. So we have to keep that in mind when we are interpreting these rates. But regardless, the rates were much lower. And similarly, we looked at for the contraceptive use rate in females with kidney transplant. And again, although the rate was higher than the women on dialysis, it was still just around 10%. And we also looked if the rates changed over a period of 8 years, and there was not a significant increase. Although the rates was a little bit slightly higher in the more recent years, but more or less they remain constant. So what is the reason that the rate of the contraception rate is so low for our patients with kidney disease? And one of the reasons is that over 65% of nephrologists lack confidence in female issues.
Good.
So this is actually one of the surveys which was done by Dr. Hendren and group, where nephrologists worldwide were interviewed with regards to management of female health issues. And the red bar indicates that nephrologists were not confident in addressing these issues. And as we can see, for most of them, nephrologists were either not confident or somewhat confident, and this included counseling on contraception as well. So we did discuss that the contraception use is low for our patients. Nephrologists are not comfortable in managing contraception for our patients. So I think the next question our group wanted to know was, what do patients think about contraceptive use? And this is another study where we did qualitative interviews for our patients with on transplant, with chronic kidney disease, and with women on dialysis, and where we asked them a series of questions and did qualitative interviews, and all the patients shared their perspectives, and we came out with five themes. So the patients agreed that they receive inadequate contraception counseling, which is often related to medical complexity, which leads to lack of interdisciplinary approach. This further causes patient frustration, lack of trust in healthcare system, often leading to patient anxiety. They also mentioned insufficient educational resources, which are available with regards to reproductive health and contraception use with regards to kidney disease, which leads them to use internet sources for education and often leads to patient isolation. And these are some of the things which our patients shared with us. So one of the patients who was on dialysis, she mentioned that I did not even know you can get contraceptives while on kidney failure, because they tell you you cannot get pregnant or you are going to die if you do, and just leave it like that. I never knew that. So basically, patients shared that they were in fact told not to use contraception by some of their doctors because they were told that they really cannot get pregnant on dialysis. And this is unfortunately, this is very unfortunate, because as we think that we did see a very high rate of pregnancy for women on dialysis. So this could be one of the reasons that women are getting pregnant, and they, most of these pregnancies may not have good outcomes. They may end up in miscarriages, and ultimately they have a lot of psychological impact as well on our patients. And that was what patients shared with us. That I lost my child in 2011. After all that, I tried to go to a Planned Parenthood to get some type of birth control because I'm in renal failure. There's nothing. They will give you nothing. And then when I asked my gynecologist about certain things like hair loss with medroxyprogesterone, she said to ask my kidney doctor. And when I asked my kidney doctor, they say ask a gynecologist. So this can be confusing. So again, showing lack of interdisciplinary care where patients are just referred from one provider to another provider, which often leads to confusion, patient isolation. So to summarize, pregnancy can occur in all stages of kidney disease. Kidney transplant restores fertility. The preferred methods are intrauterine devices and progesterone-only methods. The combined estrogen-progesterone pills should be avoided as they can worsen the blood pressure. Barrier methods have high failure rates. And birth control is important to prevent unplanned pregnancies, especially a lot of these women, as we discussed, could be on teratogenic medications like mycophenolate, and that is why it is very important for them to be on birth control. So this is briefly our role to educate them, to provide options in late-stage chronic kidney disease that kidney transplant does restore fertility. Remember the choice to support them, that the choice is theirs to make. We should assist them with family planning, provide them with contraception, and then optimize their course, like make sure they have the blood pressure is well controlled, they're on aspirin to prevent the risk of preeclampsia, and then identify the best window in their course of chronic kidney disease. And this is some of the work which we have done and the global impact which we have made. So this is the National Kidney Foundation, where I'm a part of their planning committee, and we do these kidney commute podcasts, and we have done 6 podcasts till now on women's health and kidney disease, including breastfeeding, sexual dysfunction, family planning. This is one of the conferences which we had last year on women's health and kidney disease. This was the first time KDIGO did a conference. And then last year, again, we had a controversies conference by American Society of Transplantation, where again, we talked about reproductive health with solid organ transplants, and we are updating guidelines as well with regards to pregnancy and family planning with kidney transplant. So this is one of the issues which I had guest edited. Now the journal name has changed to Advances in Kidney Disease and Health. And this has some excellent articles on women's health and kidney disease. So if you can check those out. And again, I would like to thank my family, my mentors, collaborators, without which this work would not have been possible. And thank you for having me.
Anupama ma'am, you're muted. Please unmute yourself.
Thank you, Dr. Shah, for a very excellent and eye-opener, as I should say. I was just thinking of our own scenario. The pregnancy rate in dialysis patients in India has not been that high to my knowledge. Any reason that you can think of, or what could be the reasons? Is there any impact of the malnutrition per se, or
so I think, I think it's just not captured, because as even in general, before our study came out, it was believed that women on dialysis cannot get pregnant. So whatever studies from all over the world showed a very low rate of 0.1%. And one of the reasons is that majority of these pregnancies could be just ending in miscarriages. So they are not even they would not be captured in general. Women may not even know about it because they may just go into threatened abortion or something. But because we were able to capture those rates with claims data, so majority, even if that would be, that's why we were able to capture those rates. So I think that could be the reason in India as well, I'm thinking, that we just don't know about it. They're just not captured. But these pregnancies are definitely happening, and that is why the birth control becomes so important, even for women on dialysis.
Dr. Anita and Dr. Shakuntala Modi, any comments from your side?
No, I would like to share my experience. So compared to the US data, what you have, we don't have that many number of females in our country on dialysis. The men population is more. So we have very less female population. So that's the reason maybe we may not see many patients who are getting pregnant. And most of our dialysis patients are older age group. They are most often more than 50 years old age. So we don't see much younger patients on dialysis. They would have got transplanted most often. And if they are there, they're all old age. So that could be the reason why our incidence of pregnancy is not much compared to your data, what you have shared. And it's true that we don't discuss about contraceptives to the female patients. So that's the same concept, even what we would feel, not many dialysis patients get pregnant. So we usually don't advise them of the contraception at all. Since I have, in my 20 years of experience, I have not come across any female who has got pregnant.
No, you're absolutely right. I think that could be definitely the reason that there are very few women on dialysis, and that is why the rates are so low.
Dr. Sylvie, I have a question. Dr. Anita here.
Yes.
Like, see, especially transplant, we have seen such good outcomes. Now, my only concern is sometimes if the patient goes back on dialysis and other things, a child is going to lose its childhood. Do you talk to the parents about that aspect also? What I mean is, the mother may need to go back on dialysis and quite often is going to the hospital and coming back. So that amount of time for the child is missing. Do you talk about that also with the parents when they are planning their pregnancy?
You know, we usually don't say that in the sense for women on dialysis. So if you have, we actually just tell them about risk of adverse outcomes. So if I'm counseling my patient with kidney transplant, if she does not have risk factors, you know, and she wants to get pregnant, I would just counsel about the risk, you know, that the risk of adverse outcomes. I just put those, you know, numbers or the risk factors for her. Well, your risk of preterm birth is this, your risk of C-section is this. Usually transplants do well, like, you know, overall 10 to 15 years, and they may be eligible for another transplant as well. So specifically, if that's a specific question, I don't bring that up, that if you go back to dialysis, your time may be less, because I think that's stretching it. We don't know what's going to happen. And I think that is true for any of us, right? We don't know what's going to happen in future. Even a healthy person may develop something. So I don't bring that up specifically. Yeah.
Okay. But you've beautifully brought about all the things related to pregnancy in CKD patients. It was a wonderful presentation.
Thank you. Thank you so much.
Dr. Sylvie, there's
What
one
is the plan
question
of
in the chat.
immunosuppression? Maitri, one last question to her.
Yeah, sure.
What's the plan of immunosuppression once a transplant lady gets pregnant? After 1 year, you told we would allow for pregnancy.
Yeah.
So how is that you are going to modify your immunosuppression in her, ma'am?
So I think basically they can be on tacrolimus is safe, tacrolimus or cyclosporin, and prednisone is safe too, and azathioprine is safe too. So what happens? So our center is a steroid-free center. So most of our patients are just on tacrolimus and mycophenolate. So what we do for our patients is we continue the tacrolimus, then we switch their mycophenolate to azathioprine, and then add prednisone 5. Now, if your patients are already on these 3 to start with, you can just continue them. But that is what we do. So tacrolimus, azathioprine, and prednisone. And actually patients, you know, I have just one of my patients delivered, I think a couple of months back, and she actually carried her pregnancy till term. She had no preeclampsia, nothing. So she was actually on belatacept. So I changed her belatacept to azathioprine. And so she was, I changed her belatacept to tacrolimus. So she was on belatacept and mycophenolate. So I changed her belatacept to tacrolimus. I changed her azathioprine, mycophenolate to azathioprine, and continued her and added prednisone. But those are the 3 ones which are safe.
And is that the same period what you're advising, 1 year post-transplant not to get pregnant?
You know, at least I would say at least first 6 months, definitely they should not get pregnant, because they may be, the prophylactic regimen varies as well, center to center. So a lot of these patients could be on trimethoprim for PCP prophylaxis and valcyclovir for CMV prophylaxis. So those are all teratogenic. And so at least definitely for the first 6 months, no. And we tell them to wait at least for 1 year just to make sure everything is stable. So we don't, if their creatinine, suppose now is 2 or more than 1.5, we obviously tell them like your outcomes may not be good. So we had a patient who got pregnant whose creatinine was higher. I think it was 2.1 or 2.2. And, she ended up losing her pregnancy. So only the outcomes are only good. Majority are good if you don't have risk factors to start with, which is creatinine of less than 1.4, optimal immunosuppression, well-controlled blood pressure, minimal proteinuria. But yeah, 1 year we tell them to wait.
So how early you are going to change over to mycophenolate, ma'am? Switching over
So
mycophenolate,
usually
how early you
6
plan?
weeks. 6 weeks prior to attempting conception. So, when you see them in the clinic, you just switch and you say, well, wait for 6 weeks till you start attempting conception. And continue to use your birth control for 6 more weeks. And after 6 weeks, you can, after the switch.
Okay, thank you, ma'am.
Sure.
Sylvie, there's one question in the chat box by Dr. Ramadan. He asks effect of ovulation induction or IVF on kidney disease.
So this is a great question. So we just, we just did this. This has not been looked in detail, and we actually just did a study with TPRI, which I had mentioned, which is in Philadelphia, which is a voluntary registry, which has information on IVF, and our manuscript is under review right now. But we did not find any difference in we did see a higher rate of hypertension with IVF as compared to non-IVF for kidney transplant patients, and a higher rate of preterm births and low birth weight. So we did find those 3 things, but other than that, we did not find any difference. There was no other difference in the adverse outcomes. So I think that's what we tell patients as well. Like, there could be a slightly higher risk of hypertension during pregnancy, which in general is there. There's higher risk of preeclampsia in general with kidney transplant, but IVF increases that risk a little bit further too. And there's also higher risk of low birth weights and preterm births, little bit higher than non-IVF, but there's not a lot of data behind it. So hopefully, our study should be published in the next year or so. So we'll get more information on that.
Thank you so much, Dr. Sylvie.
Dr. Maitri, a couple of questions from my end, if you can let me.
Sure, ma'am, sure.
Dr. Sylvie, it's an excellent talk, but a couple of questions. See,
Sure.
one question is like, should we encourage the young women on dialysis to become pregnant? If so, how and when? Is there a monitoring or surveillance for them? Because hormonal fluctuations are known to happen. And a lot of factors probably add like economics or probably some other conditions for not provoking them to become pregnant or something, or medically should we do a hormonal surveillance and say that probably you're good to go. So sharing a recent experience of ours in our setup also, once when we had 2 patients who were unknowingly become pregnant, we could not convince them to continue pregnancy, and the other side of it, they lost the pregnancy also, in the sense because of the uncontrolled pressures or something like that. The other side of it, our sister concern Institute Usmania Hospital had recently shared their experience of 3 patients delivering live children after complete successful pregnancies, but they had lots of challenges to go through, starting from nutrition to balancing the dialysis session, so many things. So which are all definitely not a very easy task to take up in setups like ours, wherein the motivation needs to be more, wherein the resources also need to be more. That's one long question, Sylvie. The second question is, what is the role of artificial intelligence in promoting the fertility in women? I mean, do you foresee, because AI is the AI is the mostly spoken about. So do you foresee that AI can be used in is there any scope or something like that?
So yeah, so I think those are great questions. So the first question, I would say, I don't encourage pregnancy, and I don't even think we have to encourage pregnancy on dialysis just because the outcomes are so bad. And actually, our study, reported like just 20% of live births, even though we had 30% unknown outcomes. So we don't know what those unknown outcomes were, but only 20% were live births. So I just tell those patients, if patients, the outcomes are really, really bad with dialysis. So I don't think we should encourage pregnancy, and especially if they want to, the best advice is if they are able to wait till transplant, if they have a transplant plan, or if they're able to get a transplant and they're of, not very advanced maternal age, they should just wait to get a transplant and then get pregnant, just because the outcomes are so good after that. So that is the first question. I think with intensive dialysis has shown to improve outcomes. Now, even that data is from a very small study, which only had 20 patients. But I think that is one of the interventions which can be done and which should be done, because it really improves the rate of live births. So, if we have a woman on dialysis who gets pregnant, who wants to continue pregnancy, if that was an intentional pregnancy, then we need to intensify her dialysis and in general improve her nutrition and work on other factors as well. But intensification of dialysis is one of the things which has shown to be effective. So that is, I think, the answer to that question. The second one, definitely, I think AI, I do foresee a role, of AI. And I think one of the roles could be just to predict the risk of adverse outcomes, to predict the successful pregnancy, because that is one of the most important things I think for our patients, like, will my baby be healthy and alive? That is their most important concern. Like, they want a healthy baby. In addition to, they also want to make sure if their kidneys are going to be fine. So I think I foresee a role of AI in those areas, definitely in future.
Thank you, Dr. Sylvie. Thank you so much.
Thank you, Dr. Sylvie. You've always supported women in nephrology. As soon as I requested her, like, can you deliver a talk for us? She instantly replied, yes. That was the kind of support she's given us right from the beginning. She supported many women in nephrology, nephrologists from India as well. We are very proud of you, and we look up to you, and we wish you great success in the future. You have been a trendsetter for all of us. Thank you so much for sharing your valuable time and insights with us. Thank you so much, Dr. Sylvie.
Thank you. Thanks, Matri. Thank you so much for having me.
Moving on, we'll be moving forward to the original research presentation by Dr. Pooja Prabhu. And for this, we have our chairpersons, Dr. Purnima Tatkar. She's a consultant nephrologist from Chirayu Hospital, Gulbarga. And Dr. Anaga Shreya, she's assistant professor from Ambedkar Medical College, Bangalore. Over to the chairpersons to introduce the speaker for the session and also the topic for the session.
Good evening, everyone. The topic is first trimester serum cystatin C level is a predictor of preeclampsia, a prospective study. And I would like to invite our speaker, Dr. Pooja Prabhu, who has been my senior also, who happens to be my senior. She is currently working as assistant professor nephrology at MS Ramaya Medical College, Bengaluru. And she's going to talk on a very important topic, that is cystatin C in preeclampsia. Over to you, Dr. Pooja.
Yeah, thank you. Thank you, Dr. Purnima. I would like to thank the Win India team and Win Karnataka to have acknowledged my prospective study to be presented here in this in front of the august audience. I would like to share my screen. Yeah. So is it visible? Yeah. Okay. So shall I begin?
Yeah, sure. Go ahead.
Yeah. Preeclampsia is a common complication that is noted in pregnancy, which affects 3 to 8% of all pregnancies. So there is an increased risk of maternal and fetal mortality and morbidity. Renal damage in preeclampsia is one of the key components in the pathophysiological process, but the exact pathogenesis of this disorder is still an enigma. Serum creatinine and uric acid levels have been routinely used as markers of renal damage in preeclampsia, but serum cystatin C recently has been shown to be a better marker of renal damage than serum creatinine in preeclampsia. So before going to the topic proper, I would like to tell about shrunken pore syndrome. We have seen that there is pronounced shrinking of the pore size of the glomerulus due to endotheliosis in preeclampsia. So due to the shrinkage of the pore size, creatinine, which is a smaller molecule, it gets filtered away. But cystatin C, which is a large molecule with 13.3 kilodaltons, as its molecular weight gets retained in circulation. So when we calculate the GFR based on cystatin C and creatinine, definitely cystatin C based GFR calculation will come lower than the creatinine based GFR calculation. So this ratio of GFR cystatin C by eGFR creatinine, if it is less than 0.6, then it has been used to diagnose it as shrunken pore syndrome. So the question arises whether those ladies who have shrunken pore syndrome in the first trimester, are they at an increased risk of preeclampsia? See, there are few studies which have shown that this shrunken pore syndrome did exist in pregnant ladies in the first trimester who later on went on to develop preeclampsia. But there are very few studies which have shown that serum cystatin C could be a useful marker in the first trimester to predict preeclampsia. So therefore, the need for this study was to identify a novel biomarker which can predict preeclampsia in the first trimester, help us to be more vigilant and enable a risk modifying therapy at the earliest. So the objective of my study was to determine serum creatinine levels and serum cystatin levels among all pregnant ladies in the first trimester, calculate their GFRs and look for the presence of shrunken pore syndrome, and to look for whether there was any association between first trimester serum cystatin C with the development of preeclampsia. This was a prospective study done between Jan 22 to June 2023 at Ramaya Medical College Hospital. All pregnant ladies in the first trimester, that is at 11 to 13 weeks of gestation, were included in the study. Those who had underlying comorbidities or those who had conceived with ART, those who were on anticoagulation, they were excluded from the study. So we had a detailed obstetric and clinical details were noted in the proforma, and blood samples were collected at the same time to evaluate for the creatinine levels and cystatin C levels. They were followed up every month during their antenatal visits, and they were also monitored to look for the development of preeclampsia. They were monitored till delivery, and renal functions were done on need basis. Fetal growth was also monitored by routine antenatal scans. The decision to terminate pregnancy was based on the severity of preeclampsia and the obstetrician's discretion. So the preeclampsia was defined by the criteria proposed by the American College of Obstetricians. Shrunken pore syndrome was defined as eGFR cystatin C to eGFR creatinine ratio being less than 0.6. And CKD-EPI formula was used to calculate the GFRs. Now the results. 120 pregnant ladies in their first trimester were included in our study. 10% of them were more than 30 years of age. 56 were primigravida. 10 had history of preeclampsia in their previous pregnancies. And 9 had maternal history of preeclampsia. So the mean serum creatinine was 0.46 milligram per deciliter in the first trimester, with a GFR being 142, whereas the mean cystatin C level was 1.1 milligram per deciliter, with the GFR coming to around 75 ml per minute. So the scatter plot matrix here shows that there was a definite correlation between the GFRs calculated by creatinine, cystatin C alone, or combination of the two. We saw that 17 pregnant ladies during their follow-up developed preeclampsia out of 120. There was no difference between the creatinine values among these two pregnant ladies, among these two groups, when in terms of creatinine. But in terms of cystatin C, we found that those patients who had preeclampsia had their first trimester cystatin C levels higher than the those who did not develop preeclampsia. So there was a significant difference in terms of the first trimester GFRs also for those patients who went on to develop preeclampsia. A serum cystatin C value of 1.24 in the first trimester was shown to predict the occurrence of preeclampsia with a sensitivity of 94% and specificity of 74%. So we also saw that 91 out of the 120 had evidence of shrunken pore syndrome. But all 17 patients who had preeclampsia had definitely had evidence of shrunken pore syndrome, which was statistically significant. The serum cystatin C values were also higher among those patients who had shrunken pore syndrome and subsequently went on to develop preeclampsia. So among the pregnant ladies who had preeclampsia, 7 had AKI, 2 had abruptio placenta, 6 had HELP syndrome, and 1 had eclampsia. Out of the 7 AKIs, 6 showed complete recovery after delivery. and one patient had persistent renal dysfunction at 3 months of follow-up period. Fetal morbidity was also noted among the babies delivered in preeclamptic mothers. 4 were preterm and 5 were SGA requiring NICU care. There was one fetal demise. So to discuss, we systematically evaluated renal functions among 120 pregnant ladies. We found that there was a significant difference in the serum creatinine levels and serum cystatin C levels in the first trimester. But none of our pregnant ladies had serum creatinine more than 0.8 in the first trimester. None of them had proteinuria in the first trimester. But there was a high prevalence of shrunken pore syndrome in our cohort. This was probably because the serum creatinine values among our pregnant population was very low. Most of them were from the rural areas belonging to low socioeconomic strata with a lower muscle mass. So in our study, none of them had elevated serum creatinine of more than 0.8, but 109 out of 120 had a higher serum cystatin C value of more than 0.85 in the first trimester. A study done by Campos et al. Has shown that in 74 pregnant ladies, where they also evaluated for first trimester cystatin C and creatinine levels, 8 of them had shrunken pore syndrome. So in our study, 17 ladies went on to develop preeclampsia, and all the 17 ladies had evidence of shrunken pore syndrome in their first trimester. And the serum cystatin C values among these pregnant ladies were higher, and they subsequently developed preeclampsia. A similar study by Risch et al. Has also shown that women who later on developed preeclampsia had a significant higher value of cystatin C in their first trimester. In their study, 8 preeclamptic cases were there. 5 of them had higher value of cystatin C and shrunken pore syndrome. They concluded that a serum cystatin C value of more than 0.85 in the first trimester, despite normal serum creatinine, could be a predictive value for development of future preeclampsia. Also, a study by Thilaganathan et al. Has demonstrated that there is a raised maternal first trimester cystatin C as an early marker of preeclampsia. So to conclude, there is no highly accurate method to determine the general risk of preeclampsia, especially a few weeks before its onset. Serum cystatin C level is a useful first trimester biomarker for prediction of preeclampsia. Presence of shrunken pore syndrome in the first trimester predisposes the patient to develop preeclampsia among pregnant ladies. Thus, determining the risk for development of preeclampsia in the first trimester helps us to identify the women who are at more risk for development of preeclampsia and establish early treatment and improve the maternal, fetal, as well as renal prognosis. Limitations of our study was we had pregnant ladies predominantly from low socioeconomic strata and from a rural background. And we could not evaluate for serum cystatin C levels after the onset of preeclampsia or during the follow-up period due to the cost constraint. So these are my references. Thank you.
Over to chairpersons.
Thank you, Pooja ma'am. I have 2 questions.
Yes.
One is how feasible it is to measure cystatin C levels in our day-to-day practice, and what will be the cost, and what advantage it is going to serve over serum creatinine, even if we do.
Yes. Yes, cystatin C is now available widely. So most of the big labs do perform it. The cost is a bit higher compared to creatinine levels. Because one, it is not routinely done, and the samples that they obtain may not be like the creatinines, but definitely cost-wise, it may come to around 800 to 2,000 rupees for each testing, which is definitely higher for our population or compared to the creatinines that we do. Second, most of the time we have seen that in first trimester, most of the obstetricians do not do a renal function test at all. Most of the time, the focus is not on the kidney. We don't even know that whether the patient had any pre-existing kidney problem or proteinuria, nor there has been any national guidelines on evaluating a renal function in the first trimester or recommendations also. So that's why this study was done to see whether there has any difference that we can make out of this. since even though the incidence of preeclampsia is very less, it's only 8 to 10% among the entire pregnant population. But definitely when they develop preeclampsia, it's a real thunderbolt for the mother as well as for the child. So if at all we start using cystatin C on a routine basis, probably the cost might also come down, and we will also be able to predict whether these patients are going to develop preeclampsia and try to incorporate aspirin or strict blood pressure monitoring at an earlier date.
Yeah. That was going to be my second question. That because by definition we say preeclampsia is about 20 weeks.
Yes.
So by diagnosing through cystatin C in first trimester,
yes.
how are we going to change the outcome?
No, cystatin C is not utilized to diagnose preeclampsia. It's only used to predict preeclampsia occurrence, so that you are more alert. So you're as an obstetrician, they will be more alert. As a nephrologist, you are more alert that this patient needs to be on follow-up and this patient has to be on a better checkup, because early preeclampsias are much more like you have between 20 to 32 weeks, they are called as early preeclampsia, and those preeclampsia that develops after 32 weeks is a late preeclampsia. So early preeclampsias are actually more morbid to the mother as well as to the child compared to the late preeclampsias. So sometimes they do antenatal visits only once a month, sometimes twice a month, sometimes they don't turn up even till 7 months. So these are the situations where you can pick it up early, provided the cost constraint is not there. As of now, it might be in the research field, but once it comes into routine practice, it needs further validation of this data to make it more industry friendly.
Ma'am, serum creatinine values are slightly lower,
Yes.
normal value range in pregnancy compared to the normal other adults.
Yes.
So does that hold good for cystatin C also?
Yes. What trend we have seen in terms of creatinine is that it's usually a dip is seen in the second trimester and then again a rise by the third trimester. But in terms of cystatin C, how it happens, if you look at the non-pregnant population, if you have a cystatin C among the non-pregnant population, then in the first trimester, there will be a mild elevation in cystatin C. Probably that's why we have got a little higher cystatin C value. And then there is a little lower dip in the second, and then a further continued rise in the third trimester. So cystatin C, because it is not dependent on the muscle mass and it is produced from all the nucleated cells, there is no race or gender difference. It's not modulated by any of these factors which influence the creatinine. So that's how it has formed a better marker. But as others, there are not many studies in this aspect as to what is the normal cystatin C in a pregnant population. Definitely, very few studies have told that anything more than 0.9 to 1 might be considered as a pathological reading. Because in terms of creatinine, what we tell, anything more than 0.8 as significant in pregnant ladies. Similarly, here, anything more than 0.9 to 1 has been considered as pathological when it comes to cystatin C. Definitely the methodology that is used also will matter. So what we have used here is turbidometric method. So various other methods which can be done. But Indian data in this field is a bit lacking.
Yours was an excellent presentation, ma'am. But in our day-to-day practice, currently in given situation in India, what we see, most of the pregnant lady we come across, they don't even have a urine routine done throughout their pregnancy. So to convince them to get a test worth 2,000 in the first trimester is going to be a big challenge, is what I feel personally.
Yeah, definitely. It's still a long way to go. We as a nephrologist have not yet employed cystatin C in our day-to-day practice. So I do not expect the other departments to incorporate it as of now. But still, as a research modality, since this is a very enigmatic pathogenesis or pathology that is there in preeclampsia, it's definitely a new era that can surge rise to. So because previously it was thought that the pregnancy is pregnancy, that is the placenta, which is responsible for the preeclampsia. That is the concept that has been going on, that invasion of the trophoblast into the spiral arterioles is not done well, and therefore the preeclampsia. But everything might finally land up that it is the kidneys which are responsible for the development of preeclampsia. It might finally come to our department itself.
Dr. Anita?
Ma'am, just one question, ma'am. You excluded the patients with ART, ma'am. Any particular reason, like you had any other studies which referred why we had to exclude these patients?
No. Patients, it has been, they have documented that those patients who have conceived following ART, they have a higher risk of preeclampsia. So in order to avoid that bias, we excluded them. And patients who are on anticoagulation, the cystatin C values will alter with the anticoagulation. So that is why that was withheld.
Thank you, ma'am. Very nice talk, ma'am. Thank you.
Dr. Pooja, I have last two questions.
Yes.
We already have the proven role of, predictive value of SFLT and PI-GF ratio.
Yes.
So is this cystatin C going to add anything to that, or is it more advantageous than that? What do you think?
Yeah, SFLT by placental growth factor ratio, I do not think that it is a predictive role is in the first trimester, madam. The predictive role is at around 28 weeks or so. So this is much prior to it. One, it may help us in predicting the preeclampsia. Two, it may help us in further analyzing the pathogenesis of preeclampsia. So as stated earlier, the preeclampsia may not be all due to the placental problems. It may be the kidney that is leading to these problems. We are just trying to fit into the puzzle yet. So the puzzle is not yet complete for preeclampsia.
One last question from Dr. Shweta Mehta. She asked, how early in first trimester can you do cystatin C?
How early? Most of the studies had done it at this 11 plus 13 weeks of gestation, when they really look for many things in first trimester, like even the NT scan, or most of the studies have been done. So that's why we included it at 11 plus 13 weeks. And most of the pregnant ladies also do come after the second month when they miss their periods. So that's how we have included this month. I mean, this week, that is 11 plus 13, 11 to 13 weeks. Even in the beginning, probably it may not change much in the first 3 months.
Thank you. Thank you so much, Dr. Pooja.
Maitri, can I step in, Maitri? A couple of questions from my side, Maitri.
Sure, ma'am. Last 4 minutes, finish it.
So, Pooja, an excellent work, truly commendable work. But then, there are no standards for cystatin, even for that preactin in the first place. So that basically forms a shortcoming in the whole scenario. That's one. The second thing is, unless an RCT is there, we may not be able to generalize the utilization of SPS in predicting preeclampsia. And as far as we know, it is not much in preeclampsia, though the SPS has been enlisted for cardiovascular outcomes, blah, 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 blue. But in preeclampsia, it's not much. The third thing is, even after doing this, even after knowing that, how far are we going to implicate it in corrective methodology? In the sense, I predict preeclampsia. So am I going to have a therapeutic implication on that? So the fourth thing has already been mentioned. My group has 500 plus patients of brachys, out of which 44.5% are preeclamptic patients. So the menace of preeclampsia is going to increase tremendously in future. The factors, the etiologies, we may not know much, but then, as you said, prediction is definitely the central crux of it. But then, if you could have added, if there is more substance to be added, like just not the SPS, but then detecting that NO, other factors, and also looking at the uterine artery Doppler, something probably could have strengthened the study more. No, your study is good, but only these are the few suggestions. Again, routine clinical application becomes extremely difficult. I think I am done within 2 minutes, Maitri. Thanks for the time. Yeah.
Yes, ma'am. Definitely, ma'am. We have while doing the study felt a lot of shortcomings. It's one thing is that the funding for the study and all that also matters. Like to extend this study in different aspects. So probably it's just a pearl in a big ocean that we have just started it off. Maybe there will be future studies which will help what I would like to tell is, like, if we predict preeclampsia earlier, there may be some other group which might be doing some study on how to improve the management of preeclampsia. There might be some therapeutic options that might come up. So everything, like everyone's contribution to the preeclamptic ladies. So yes, ma'am. So we'd really like to.
Thank you, Dr. Pooja.
Probably
One comment, Maitri. You should apply to ICMR, ask for multi-center study across India. It will become much more strengthened.
Yes, yes,
Okay?
definitely, ma'am.
Thank you.
Yes, ma'am. Thank you. Thanks a lot, ma'am. Thanks for the opportunity.
Thank you, Dr. Pooja. This was our first initiative where we just invite original research articles, and then we select from the applications, and the best research paper the person who has conducted best research among that gets to present in Win Karnataka webinar. So it is an open platform and a very transparent process. So I encourage all women in nephrology Karnataka chapter to apply your original research work to us, and you have an excellent platform to display your research work in our upcoming webinars as well. Thank you so much, Dr. Pooja, for initiating this initiative on original research work. Thank you so much.
Thanks a lot, ma'am. Thanks for this opportunity.
Next, we move on to the next session. I invite the chairpersons, Dr. Indu Ramchandra Rao. She's consultant nephrologist from KMC Manipal. Dr. Divya, consultant nephropathologist, MS Ramaya Memorial Hospital, Bangalore. And Dr. Shweta Mehta, consultant nephropathologist, Kaveri Hospital, Bangalore. I request our chairpersons to kindly introduce the speaker and the topic for the session.
Good evening, everybody, and thank you for inviting me today. It's my pleasure to introduce the speaker for our next session on technical aspects of renal pathology. Dr. Gnanapriya V is a nephropathologist at St. John's Medical College, Bengaluru. Please join me in welcoming her to share her insights with us today. Madam, the floor is all yours.
Gnanapriya, we can't hear you.
Madam, you seem to be still muted. Could you please unmute yourself?
Dr. Gnanapriya, we can't hear you.
I've unmuted myself. Is it audible?
Yes, we can hear you.
Sure.
Can you start right from the beginning? We missed.
Okay. Yeah.
We couldn't hear.
Yeah. Good evening, one and all. I'm going to talk about for the next 20 minutes regarding technical aspects of renal pathology. I have introduced some diagnostic aspects also in the PPT so that it will be more interesting for the audience. Coming to the biopsy protocol of fixators, as we all know, renal biopsy is an essential technique in diagnosing renal diseases. And while diagnosing, we need to take care of the adequacy of the tissue which is being sent to the lab. So the adequacy can be evaluated at the bedside or in the lab by using either a dissection microscope or by using a standard light microscope or even an immunofluorescence microscope. Suppose if these techniques are not available, even you can use a simple hand lens to look for adequacy. So this is a picture of a renal biopsy, which is viewed under your dissection microscope. In the cortex, the glomeruli appear these small round red areas, whereas in the medulla is devoid of such glomeruli and the vasculatures are evident. So in case where the direct assessment of glomerular techniques are not being available, then the standard approach can be practiced. So in the standard approach, basically the edge of the biopsy, that is the 1 millimeter edge of the biopsy to be procured for electron microscopy, and the remaining tissue is cut into two. The bigger one will go for your light microscopy and smaller one for immunofluorescence. Suppose if you got a second core, the same technique has to be followed. That is the edge of the core will go for your EM and the remaining tissue will be cut into two. This time, the smaller one will go for your light microscopy, whereas the bigger one will go for your immunofluorescence technique. So by this way, at least you can ensure that the adequacy of the glomeruli will be there in all the three modalities. So the most common preferable fixative for light microscopy is your 10% neutral buffered formalin. For immunofluorescence, you can use either a Michel's media or a saline. But if you're sending it in saline, you need to take care of that it should reach the lab as early as possible, preferably within a half an hour to 1 hour time. Whereas in Michel's media, generally the sample is stable for at least 5 days if the temperature is less than 35 degrees. For electron microscopy, the preferred fixative is 3% buffer glutaraldehyde. So once the biopsies are processed for light microscopy, either you can use a overnight processing for routine biopsy. Suppose if the biopsy is urgent or if you are sending a transplant biopsy, then short processing techniques can be followed so that you can get the results on the same day. So in the once the biopsies are being embedded with paraffin wax, then the sections are being cut, 2 to 3 micron thick sections are being cut from the paraffin blocks, and then generally the serial sections are cut and then they are generally stained with multiple special stains. The most important stains which has been used in renal pathology in contrast to other pathology is your periodic acid shift, MT and silver methenamine in addition to your conventional hematoxylin and eosin stain, because each stain will complement each other. So hence it is important to use all the stains when you are interpreting your renal biopsy. Apart from that, you can use certain additional stains such as Congo red on a case-to-case basis. Suppose if you are suspecting any organized deposition disease, you can go for Congo red. Or if if there is an elderly patient who's presenting with a very heavy degree of proteinuria, then Congo red stain should be employed to rule out any organized deposition disease. While interpreting a renal biopsy, we should go it in a hierarchical way of interpretation, that is starting from the glomerular compartment, then move on to the tubules and next to the interstitium and last the blood vessels to be interpreted. This is a table basically showing highlights the use of different stains in renal pathology. So this is a PAS stain and this is a silver and an MT stain. In addition to HNE, these three stains are must in renal pathology. Basically, PAS and your silver methenamine stain, it highlights the mesangium as well as your basement membrane of your capillary wall, Bowman's capsule, tubular basement membrane as well as blood vessels. In PAS stain, the structure, that is your mesangium as well as your capillary wall, generally take up the magenta colored or the red color, whereas in silver stain, it will look black color because it's a silver, so it will stain black color. So anything, the foreign material, that is your immune complex or any organized deposits, if it is getting deposited in the renal biopsy, it will be either a weakly PAS positive or negative with your PAS stain, and it will be negative for your silver stain. The fourth stain which is commonly employed is your MT stain, that is your Mason's trichrome stain. Trichrome means basically you will see three colors within the biopsy. That is why the term trichrome. So here, the basically MT stain is most commonly used to highlight the interstitium. The interstitium appears either as a blue or blue or green in color, depending on the counter stain being used. In our lab, we are using light green. So hence, the interstitium appear green in color. In addition to look for interstitial fibrosis, MT stain is commonly used to look for your immune complex or even your fibrinoid necrosis. So both immune complex and fibrinoid necrosis look red color in your MT stain. So this is a case of lupus nephritis where your hyaline thrombi and your subendothelial hyaline deposits have taken up the red color stain. So empty stain is otherwise even called as a poor man's electron microscopy. Suppose in case if you don't have an immunofluorescence, and if you're seeing these reddish deposits in the capillary wall and in the mesangium, it indirectly suggests that what you're dealing is an immune complex mediated disorder. So coming to the next important technique which gives much information about your renal biopsy is your immunofluorescence technique. Basically, in immunofluorescence, we are identifying the antigen in the tissue by using a fluorochrome label antibodies. Though the commonly used fluorochrome is your FITC, that is fluorescent isothiocyanate. Basically, it gives a green color fluorescence. Apart from FITC, you can use even other other fluorochromes such as your TRITC or Texas red. So in immunofluorescence, basically, whatever the tissue which are received in mishals or in saline, they are snap freezed and they are cut in a cryostat at -20 degrees Celsius. Once the sections are being cut, then they are stained with these fluorochrome labeled antibodies. And they are viewed under these immunofluorescent microscope. So the commonly used antisera in immunofluorescence is your IgG, IgA, IgM, C3, C1q, kappa and lambda. The other things are optional. That is your IgG subtyping, albumin and fibrinogen. They are optional. So once the immunofluorescence procedure is being done, you have to interpret whether it is showing positive or negative within particular compartment. If it is positive, then you have to locate where it is being positive. That is whether within the glomeruli. If it is within the glomeruli, you have to identify whether it is within the mesangium, capillary wall, or mesangium and capillary wall, or within a podocyte. Suppose if it is in the extraglomerular compartment, then the deposits are being showing positivity, that needs to be recorded. So apart from the location, the pattern of deposits is also important. That is whether either it is a linear, pseudo-linear, or granular, or whether it is smudgy. Generally, the interpretation is done on a scale of either 0 to 3 plus or 0 to 4 plus, depending upon the lab which they are practicing. In our lab, we use a scale of 0 to 4 plus. So the antisera, whatever I have shown, that you can even done by a technique called as a immunohistochemistry. In contrast to immunofluorescence, in immunohistochemistry, you are using a chromogen-based technique, meaning you are using a chromogen which produces a color. Whereas in fluorescence, you are using a fluorochrome-stained antibody which emits fluorescence. So both the methods, it provide an excellent material, but for many nephropathologists, immunofluorescence is considered as a choice. The advantage of immunofluorescence is it provides a very high signal noise ratio and provides a very good resolution in locating your immune complex. However, the drawbacks with regard to your immunofluorescence are they are not permanent techniques. So the fluorescence will quench over sometimes. So you need to take photos of the positive ones, and you need a special microscope to view this, and you need an additional sample to be sent in mishals or in saline. Whereas the immunohistochemistry, for this, you don't need an extra biopsy. You can done even with your formalin-fixed paraffin section, that is with your light microscopy biopsy, and you don't need a special technique. And these sections are considered, they are permanent section, they never fade over time. But the drawback with immunohistochemistry is each antigen has its own retrieval time, so it is more time consuming. Sometimes it can produce even a background staining. Hence, immunofluorescence is preferred in most of the places. So in order to interpret a renal biopsy by immunofluorescence, you need to know whether your technique is being working well or not. For that, you should look for the internal control. The one such internal control is if the biopsy is stained with IgA, the cast, that is your hyaline cast, which is seen in the renal biopsy, they generally show fluorescence with your IgA because they are made up of your secretory immunoglobulins. So hence it's stained brightly with your IgA. So in IgA, if your hyaline casts are being positive, you know that the technique what you're doing is working well. So apart from that, you can even look for protein resorption droplets in IgG, which also serves as your internal control. So how to interpret the immunofluorescence? Basically, you look at the compartment, look for fluorescence. So this is a globe where it is not taking up any fluorescence. So this is considered as negative. And if it is considered as positive, you need to locate where the positivity is, whether it is in the mesangium or in the capillary wall. So how to identify whether it is a mesangial or a capillary wall positivity? Suppose if you remember a tree with a trunk and stem and branches, if the pattern of positivity is similar to something which is there in the trunk, stem, and branches, you will call it as a mesangial pattern. Suppose if the pattern of positivity is around your trunk and stem of the tree, you will call it as a capillary wall pattern. So once the location, you can even have combination of these two, that is your mesangial as well as capillary wall pattern. So once the location has been identified, then you need to interpret the pattern of positivity, that is whether it is a linear, granular, or smudgy. So here there is a mesangial pattern of positivity and it shows granules. So it is a granular pattern, and here the granules coalesce to each other at many places. So we call it as a confluent granular positivity with IgA in the mesangium, which is more commonly seen in your IgA nephropathy as well as your HSP nephritis. In this case, you're seeing again granular positivity in the capillary wall, but here the granules appear too fine, which is called as a fine granular capillary wall positivity for IgG, which is diagnostic of your membranous nephropathy. So here the globe is stained with C3, which is showing a coarse granular, meaning the granules are not fine, they are bigger and smaller. So this is called as a coarse granular positivity, and the positivity is in the capillary wall as well as in the mesangium. So when you have a dominant coarse granular deposits for C3, the two disease which comes to your mind is your C3 glomerulopathy as well as your PIGN, otherwise called as an infection-related GN. Then comes a linear pattern of positivity. If you compare it with the previous figures, here we can't appreciate any granules over here. Here it's just like a straight line, hence it is termed as a linear positivity. So when you see a strong linear positivity for IgG in the capillary wall, that is diagnostic of your anti-GBM disease. Again, if you compare it with the previous figure, this also appears linear, but the intensity is much lesser as compared to the previous disease. This is called as a pseudo-linear, otherwise called as a linear accentuation. Here, the term pseudo-linear being used, this is commonly seen in diabetic nephropathy. It is called a pseudo-linear. It is because the positivity is not really due to your immune complex. It is because basically the plasma proteins are getting entrapped in the basement membrane, which leads to these linear accentuation, or otherwise you call it as a pseudo-linear. To confirm it, you can use something called as an albumin stain, which again produces these kind of a linear pattern of positivity in all the basement membrane, that is in your glomeruli, in your tubular basement membrane and everywhere. So this is a tubule which is showing protein resorption droplets, which is highlighted by this albumin stain. Then comes a smudgy pattern of positivity. Here, the pattern of positivity neither looks linear nor granular. It looks smudgy, hence the term smudgy. So when you see these kind of smudgy pattern of positivity in the mesangium and the capillary wall, it is diagnostic, or you can 100% be sure that what you're dealing is a fibrillary glomerulonephritis. So apart from these, apart from these positivity, you might see these kind of a dusty granular kind of a positivity within the cytoplasm of the podocyte. So when you see these kind of dusty granular positivity, especially in podocytopathies, it indirectly signifies that the patient might have anti-nephrin antibodies in the serum. So whatever the immunoglobulins and the complement, that is your IgG, IgA, IgM, C3 and C1q. So when all three immunoglobulins and two complements are being positive, we refer it as something called as a full house pattern, which is more commonly seen in lupus nephritis. So apart from lupus nephritis, there are several other renal diseases where you can get full house pattern, which includes your membranous nephropathy, IgA nephropathy, IRGN, as well as your C1q nephropathy. So apart from glomerular compartment, you need to look at the extraglomerular compartment also for the immune deposits. So when you see these deposits in the extraglomerular, say for IgG, the deposits are in the TBM, blood vessels, as well as your small peritubular capillaries. This is more commonly seen in cases of lupus nephritis. In lupus nephritis, in addition to these extraglomerular positivity, sometimes you may tend to see these phenomenon, which is called as a tissue ANA phenomenon. This is nothing but the epithelial cell nuclei will show these kind of a granular pattern of positivity or speckled positivity, which is similar to in the serum, what you see. When you use a hepto cell line to identify ANA positivity, the pattern of positivity looks similar to that, but you're seeing these kind of positivity in the tissue, hence the term tissue ANA phenomenon. This is generally seen in cases of lupus whenever the ANA titers are quite high. So apart from lupus, there are several other diseases. You can see these extraglomerular positivity. One such disease is your anti-brush border associated antibody disease. Suppose in an elderly male who is having a progressive renal failure, light microscopy is showing an ATI kind of a feature, but on immunofluorescence for IgG, if you are seeing these granular kind of a positivity along the tubular basement membrane as well as in the brush border, then you should suspect these ABA, that is your anti-brush border associated antibody disease, otherwise called as a anti-LRP2 nephropathy. So to confirm that it is an anti-LRP2 nephropathy, you have to use these special antibody, that is your LRP2 antibody, which stains similar to your IgG, that is it again stains the proximal tubular basement membrane in a kind of a granular pattern of positivity as well as your brush border, as similar to your IgG, to confirm that it is an anti-LRP2 associated nephropathy. So apart from ABA and lupus nephritis, extraglomerular staining are seen in several other diseases such as your IgG4 disease, BKV nephropathy, and C3 glomerulopathy. And even sometimes when you use drugs such as like your eculizumab as well as your NSAIDs, it can even show the focal TBM positivity in the renal biopsy. So why do we need to use kappa lambda when we are interpreting the immunofluorescence? Basically, it tells about the clonal nature of the disease, what you are dealing with. Suppose if you are seeing both kappa and lambda being positive along with your immunoglobulin, you know what you're dealing is a polyclonal disease. Suppose if you have only one light chain being positive, then you are labeling it as a monoclonal. So this is a case of a light chain amyloidosis where the lambda light chain is being positive within the amyloid. So we call it as a AL amyloid. And this is a case of a proximal tubulopathy, whereas within the proximal tubular cytoplasm, the kappa is lighting up, whereas the lambda is being negative. So apart from these two diseases, there are several other diseases where it can show monoclonal pattern of positivity, which is more commonly seen in your organized deposition disease, that is your amyloidosis, fibrillary GN, immunotactoid, cryoglobulinemia. Apart from that, you might see these monoclonal positivity in MIDD, that is your LC light chain heavy chain, as well as your light chain as well as an heavy chain deposition disease, and PGNMID and membranous like glomerulopathy with masked IgG kappa deposits as well as your cast nephropathy. So this is a basic table to tell us how to approach a case when we are seeing positivity in the immunofluorescence. Suppose if you are seeing a linear pattern of positivity in the biopsy, you should suspect anti-GBM disease. Suppose if the positivity is pos-immune. Pos-immune means when the intensity is less than 2+, we label it as a pos-immune. So when there is a paucity of glomerular staining, it is based on the clinical feature. Either you call it as a pos-immune GN or MPA, GPA or EGPA. It's based on your clinical as well as your lab features. Suppose if you're finding positivity with the immunoglobulins and complements, then you need to look at the location as well as the pattern of positivity. Based on that, the other immune or immune complex mediated disorders are diagnosed. Apart from immunofluorescence, we use several immunohistochemical markers in diagnosing renal disease. The most commonly employed or used marker in renal biopsy is the PLA2R, which is used in membranous nephropathy. So in the PLA2R staining is like your mirror image of your IgG staining in membranous nephropathy. That is, it stains the glomerular capillary wall, and the staining looks like a very fine granular pattern of positivity in the capillary wall. As we all know, apart from PLA2R, there are several loads of antigen which is being discovered in membranous nephropathy. So from Mayo Clinic, they have proposed this consensus report on membranous nephropathy in identifying the antigens in cases of membranous nephropathy. What they have advised is first use PLA2R and NEL1. If both are negative, then based on the etiology of the disease, you can select the antigens which you need to run, or you can, this is called as a target approach, or you can go for a panel-based approach. That is, first you do PLAR and L1. If it is negative, then you do the most common antigens which is there in your population, then go for the least common antigens. Otherwise, you can go by mass spec, that is your proteomics, to identify what is the antigen which is causing membranous nephropathy. The other important IHC which has revolutionized, I can say, the renal pathology is DNA JB9, which is nothing but a heat shock protein, which is increased in cases of fibrillary GN. This is one of our case of fibrillary GN. The DNA JB9 stains the mesangium as well as the capillary wall positivity in that particular case. And prior to discovery of these DNA JB9, we all know that fibrillary GNs are essentially, or it will be always diagnosed by electron microscopy. So after the discovery of DNA JB9, you can almost skip electron microscopy and you can use this marker alone to diagnose fibrillary GN. And if you take about transplant biopsy, the essential marker which you need to run in transplant biopsy is your C4D. Basically, C4D is run to identify these complete linear kind of a positivity in the peritubular capillaries, which is seen in cases of C4D positive antibody-mediated rejection. This can be done either by using your immunohistochemical technique or by using immunofluorescent technique. But compared to immunofluorescence, immunohistochemical technique is considered more sensitive. So apart from C4D, the other common immunohistochemistry which you can do in transplant biopsy is SV40, which basically highlights the viral inclusions in your BKV nephropathy. This is a case of BKV nephropathy where these SV40 stain highlights the viral inclusion which is present in the renal biopsy. It not only helps in diagnosing BKV nephropathy, it also adds a it is one of the essential criteria for your PVL scoring in case of BKV nephropathy. So coming to the other important anti-sera, it is considered as optional, but I can say it is an important technique which everyone should do in in the lab, which is nothing but your IgG subtyping. So it helps in understanding your etiopathogenesis of your disease. This is a case of flower positive MGN, where generally it shows a IgG4 predominance. Apart from understanding the etiopathogenesis of disease, IgG subtyping also helps in confirming the monoclonal nature of the renal diseases. So in case of, this is a case of proliferative glomerulonephritis with monoclonal IgG deposit, where it is showing IgG3 monoclonality. So in most of the cases of PGNMIDD, generally we see IgG3 kappa dominance. So it helps to confirm that what you're seeing is a case of PGNMIDD. So apart from these conventional immunofluorescence, you can do a paraffin immunofluorescence. Paraffin immunofluorescence, initially it has been considered as a salvage technique. In contrast to immunofluorescence, here in paraffin immunofluorescence, the technique is done in the paraffin embedded sections. Okay, so basically it is the light mic in the formalin fixed section, you are doing the immunofluorescence technique. But because of fixation, generally the antigens are cross-linked. So that the sections needs to be treated with enzymes such as proteinase K or pronase to expose the antigenic sites so that the antibody what you're using will go and bind to the antigen and it produces a immunofluorescence. The most common indication, as I said, is salvage technique. Suppose if your the biopsy what you have sent for IF is inadequate, then you can use a paraffin immunofluorescence technique to come for a diagnosis. The other important indication for paraffin immunofluorescence is unmasking technique. Suppose if the antigens are masked, say in case of a crystalline proximal tepilopathy, these paraffin immunofluorescence, it unmasks the antigen and it helps to understand, or it helps you to make a diagnosis that there is a restriction what you are dealing with. However, one needs to understand that there are certain limitations or pitfall with this particular technique. The limitations are the paraffin immunofluorescence is less sensitive in certain diseases. The most common such diseases are your C3 glomerulopathy as well as your anti-GBM disease. You might not see, or you may see less intense positive with your paraffin immunofluorescence. And the other pitfall is in compared to your routine immunofluorescence, the paraffin immunofluorescence, the intensity is always 1+ intensity lesser than your conventional immunofluorescence. This is one of our paper where we have compared the intensity of paraffin immunofluorescence with the conventional immunofluorescence in case of lupus nephritis. We can able to make out that the paraffin immunofluorescence intensity is much lower than the conventional immunofluorescence. So suppose if the biopsy per se has a 1+ intensity or 2+ intensity, you might or might not see positivity with paraffin immunofluorescence. That one needs to be aware of when you are running your paraffin immunofluorescence. So coming to the other important technique or the other essential technique for diagnosis is your electron microscopy. As I said earlier, the preferred fixator for electron microscopy is your buffered glutaraldehyde. Apart from that, you can use several other medium to for electron microscopy. That is, you can even use fresh tissue fixed in formalin, but one need to remember, when you are sending tissue fixed in formalin, then that is not an ideal tissue for measuring the basement membrane thickness, because formalin generally causes shrinkage artifact. Then it is not ideal to measure your basement membrane thickness. So then you can send even tissues reserved in measures, then you can transfer it in glutaraldehyde, or even you can retrieve the tissue from paraffin block or frozen block. In least or in the last resort, even you can retrieve the tissue from an unstained paraffin or a stained paraffin section for ultrastructural studies. So once the tissues are fixed with glutaraldehyde or followed by post-fixation technique, generally they are, before viewing for ultrastructural studies, femithane sections are being cut, that is 0.5 micron to 1 micron thickness sections are being cut, and they are stained with toluidine blue. This is a toluidine blue stained semithin sections. Basically, this is being done before ultrastructural study to understand that you have areas, you will select areas for ultrastructural study, and you will be ensured that you are selecting a proper area for ultrastructural studies. And generally 1 to 2 glomeruli should be visualized for ultrastructural study. So apart from glomerular compartment, even you need to look at the tubular, interstitial and vascular compartment also. So these are the several studies which stress the importance of using electron microscopy in diagnosing renal diseases. According to these studies, EM is crucial in diagnosing renal diseases in up to 25% of cases, whereas in 50% of cases, it helps in contributing the renal diagnosis, or even it helps in refining the diagnosis, what is being given on based on your LM and IF. So there are certain diagnoses which can be overlooked without electron microscopy, that one you need to remember. The most common such diagnosis is nothing but your Alport syndrome and thin basement membrane nephropathy. Apart from that, the organized deposition disease, that is your amyloid, immunotactoid, fibrillary and cryoglobulinemic GN, collagenofibrotic glomerulopathy, and even your lipoprotein glomerulopathy, PIG, that is your podocyte infolding glomerulopathy, and early transplant glomerulopathy. For diagnosing these diseases, you need EM. Of course, now for certain diseases, we have IHC markers to diagnose. That is for fibrillary GN, we have DNA JB9. For dense deposit, this is recently discovered ApoE is there to diagnose dense deposit. Similarly, for collagenofibrotic type 3 collagen, IHC are being available. So basically, electron microscopy is done in cases to understand the extent of podocyte effacement in case of podocytopathies, in case of immune complex mediated diseases, to confirm that it is an immune complex disease and to identify the location of the disease, and in cases of basement membrane disorder, say for example your thin basement membrane disease, it helps to identify your thinning of a basement membrane, and lamellation of your basement membrane in cases of your Alport syndrome, and in case of TMA, it highlights the endothelial swelling as well as the subendothelial lucency of your glomerular basement membrane. It also helps in confirming the organized deposition disease, such as your amyloid, fibrillary GN, immunotactoid, and collagenofibrotic nephropathy. In amyloidosis and fibrillary GN, generally it shows randomly distributed fibrils. Based on the thickness of the fibril, you will be distinguishing amyloid from fibrillary GN. Whereas in case of immunotactoid GN, generally the arrangement is in the form of microtubules, that is, it is in a tubular form with a central hollow core. And in case of collagenofibrotic, you tend to see these kind of a banded collagen fibrils within the mesangium as well as in the capillary wall. So hence, as for a renal pathologist, we need a complete clinical information, and that has to be integrated with your light microscopy, electron microscopy, and immunofluorescence to arrive at a complete diagnosis. So without all these, sometimes the information will be, or the diagnosis will become incomplete. I would like to thank the organizers, that is Win India, for giving me this opportunity. And I would like to thank my mentors, that is Dr. Ritambara Nada from PGI, Dr. Vinita and Dr. Manoj Jain from SDPGI, who have trained me in and who have given knowledge in nephropathologist. And I would also thank all my staff and my technicians in my department who had given such good sections so that I can present it anywhere. Thank you.
Over to the chairpersons.
Hello.
Yes, ma'am, you're audible.
Yeah, thank you for the wonderful presentation, Dr. Gyanpriya.
Thank you,
The
ma'am.
images were very apt to the to what you taught, and thank you so much.
Just a moment. I think Dr. Ganapir, you can stop screen share.
Sure.
Go on, ma'am. Please continue.
Yes, so I just wanted to thank you. It was a wonderful presentation. Currently, I cannot think of any question because everything was explained very well.
Thank you, Shweta. Thank you.
Yeah.
Presentation. I congratulate you for that, Gyanpriya. And I have one question. When do you choose to do the subgroups of IgG?
IgG subtyping.
Subtyping.
Yeah. It is
on what cases you choose?
For PGN-MIDD, in order to say it is a PGN-MIDD, you need to do IgG subtyping to say, because most of the PGN-MIDD, that is your proliferative glomerular nephritis with monoclonal immunoglobulin deposit, generally it show IgG3 restriction. So before saying it is an PGN-MIDD, you need to advise IgG subtyping to confirm that what you are dealing is a PGN-MIDD. Of course, you need it in heavy chain deposition disease, because in heavy chain deposition disease, it will light up only for IgG. You won't find any light chains within the biopsy. So if you do IgG subtyping, and if you are finding a particular IgG subtype, you know what you're dealing is a IgG type of heavy chain deposition disease.
I have one question, Dr. Gyanpriya.
Yeah.
So for membranous nephropathy, do you run a panel or you do a targeted approach beyond?
Currently, we are running PLAR alone in our lab, and we are outsourcing for the remaining markers to Lalpath lab. That is, they are running the remaining 4 markers now. There is thrombospondin, semaphorin, exhaustosine 1 and 2, and NEL1. I think recently they have added PCDH7 in their panel approach also. So whatever PLAR negative cases, we are sending it to Lalpath for identifying these antigens. Because these antibodies are concentrated, it becomes difficult to dilute it and do it in all the cases. So currently we are outsourcing. In future, we might run it in our lab also.
Thank you.
Any other questions from any of the panelists?
Hi, Dr. Gyanapriya. It was an excellent talk. I think you've done a wonderful job of, covering a very vast topic in such a short amount of time. So it was an excellent presentation indeed.
Thank you.
I just have one question. So there was a paper, I think a couple of years back, where authors have described, on electron microscopy, finding these dysmorphic lysosomes in patients with CKD-U. So I was just wondering if you have come across any such cases in your
Dysmorphic
experience.
lysosomes can be seen in so many conditions, actually. Even if you take cases of proximal tubulopathy, you might see dysmorphic conditions, and even drugs can cause dysmorphic lysosomes, actually. So dysmorphic lysosome per se, we cannot, it's not a diagnostic feature of anything. Suppose if I'm suspecting a proximal tubulopathy, and if I'm seeing some kind of a restriction within the proximal tubular cytoplasm, and if I'm seeing dysmorphic lysosomes on electron microscopy, we might take it as a clue of proximal tubulopathy, non-crystalline variant of proximal tubulopathy. Pure as such dysmorphic lysosome, based on that, you cannot give one definitive diagnosis by electron microscopy. You need to integrate the other clinical IF, LM, and other features also.
Yeah. So do you think that this finding, may be a pointer that there is a tubulotoxic mechanism occurring in?
Definitely. It might be due to your drug, or it might be due to your monoclonal chains, which is causing injury. So it is indicating that there is some kind of injury which is going on. But to say what kind of injury, you need the other modalities to come to a diagnosis, actually.
Thank you so much.
Thank you.
Manjusha ma'am?
Yeah, I have a question actually. So, I mean, see, excellent talk, obviously. I mean, you have dealt with basics, and then, it's a great learning, obviously. But then, see, advancing the things, AI has become like for both radiology and pathology, but AI hasn't taken over radiology and pathology. AI has been there in the field, But then I feel there's a long way for AI to take over the pathology and the radiology. See, a lot of AI was done, I think, in IgA or something, one particular disease, not the other diseases. So, I mean, if you can comment on that question, AI in pathology, that's one.
I
The
I
second,
would say it never replaces a pathologist.
yeah,
AI, it never
definitely,
replaces a
yes.
pathologist, because anything artificial thing which is coming in our life, it needs a human assistance for doing it. It never replaces a human, because I don't think so it will replace a pathologist. Currently, AI is being explored in almost all the areas of renal pathology, starting from your IgA, lupus, transplant, so many conditions they have used AI. Basically, it is now AI has been used in scoring system. Basically, suppose if you take lupus, they have used AI to assess the activity and chronicity indices. Similarly, in IgA nephropathy for scoring mist, to identify the IFTA. So those are the things now AI are being used routinely actually. Even in our department, it's almost in the process of setting up an artificial intelligence department, and even we are planning to do it. But it will take some more time. We are all in the process of doing it, but it just helps a renal pathologist. It lessens our, basically it will reduce our work in doing all these scoring, doing all the assessing the percentage of involvement, this, that, and all, but it can never replace a renal pathologist or even any pathologist, I can see.
Any doctor for that matter, not just a pathologist, even the radiologist. See, radiology, pathology were the main target when
Because
the AI has entered the
it's
medical
not
field.
only the LM you're interpreting and giving a diagnosis. Here you need to interpret your clinical, your LM, your IF, your EM, and you have to combine and you have to arrive at a diagnosis. So which will be difficult for by using AI alone actually. If it's a conventional routine case, it might give a diagnosis. It will give a diagnosis, but for not for all. That is what I feel actually. Currently, it is all being employed. These AI techniques are being employed for only scoring-based systems.
Yeah, yeah. Another question is like, there is lot of battery of antigens for the membranous nephropathy. I mean, see, science is developing, but at the same time, a lots to learn, and then, dependability and all this. So do you foresee that, see, now we have certain conditions where you forego the biopsy, depend on plateau, like a biomarker, and then definitively say that the patient's got MN, cut the biopsy if the indications are not there for biopsy. So do you foresee such similar situations in other glomerular diseases as well? If not in future, probably a long way to go, but is it going to happen? And another thing is, where is the end for this battery of antigens? I mean, every day, so
As long
new
as long
antigen.
as long as
A
we
new antigen
identify.
comes into picture. I mean, it's so confusing. You say thrombospondin, exostotin, something, something, then another one, then another one. So many. I mean, it is.
I think, ma'am, that we need to ask Mr. Sethi and
Sethi.
Arhana group people that if when they stop doing these proteomics, then the number of antigens might be reduced. But obviously, it is helping, because previously when the PLAR was discovered, we know only the PLAR is the common antigen for primary MN. Even the we classify MN as primary and secondary. Now that classification only, it's been completely changed. We are going by antigen-based approach, that is PLAR associated membranous, NEL1 associated, because you can even find in primary as well as your secondary causes also. You cannot strictly go by primary by secondary. And now what they are discovering antigens, they are going by etiology based. They are taking syphilis cases and they are looking for the antigens. They are taking patients with hematopoietic stem cell transplantation and they are coming up with an antigen. I think that will help us. Suppose if we don't know the patient is having autoimmune diseases, all our autoimmune workup is coming negative, but if exhaustion is lighting up, you know that the membranous, what is being developed is due to autoimmune disease. Maybe might be at present the patient may have negative autoimmune features, but in future he or she may develop all those features, because we know in lupus nephritis some percentage of cases will be ANA negative. They will be negative for antibodies at the initial point of presentation, but in over the time course they will develop, or they may develop these ANA positivity and other things. So I think these are helping. Maybe the treatment modalities, except for some diseases, the treatment modalities are not being tailored like for how for your PLAR associated MN. That is not the, maybe that will develop in future.
Dr. Jnanapriya,
Yeah,
Dr.
thank you.
Anita here.
Thank you, ma'am. Thank you.
Dr. Anita here. I just I appreciate the way you just put across the renal biopsy. It was a recap of Dr. Mahesha, what he was teaching us when we were postgraduates in Manipal.
Okay.
It was very nice. And I have a patient as of now who is around 60-year-old, presented with membranous, biopsy PLA2R associated, but she started developing leukopenia and a thrombocytopenia. Now I'm working her up for even lupus and other things. Meanwhile, just today evening, I got her C3 and C4 being very low, extremely low. So no clinical features, just like how you were just now telling us.
Actually, there are some reports or even papers which has been published saying that it's not even one antigen you can find in membranous nephropathy. Sometimes you might end up in seeing two antigens also. I don't know, maybe if you can send it for exhaustocin, in this case, exhaustocin and L1, these two are the one which can be associated with your autoimmune related membranous nephropathy. Suppose if it comes positive, you know what you're dealing is along with PLAR might be an autoimmune associated membrane also. Yeah.
Yes. Yeah, sure. Thank you very much.
I think we'll wind up. We have already crossed the time limit.
One second.
Yes, ma'am.
See, final question to Gnanapriya. See, doing exhaustocin 1 and 2, whatever it is a tongue twister to me.
Okay.
So 1 and 2, I mean, even before the electron microscopy changes of lupus nephropathy, is it possible? Like, let's say you have membranous nephropathy and then you send the sample for exo, and then it comes positive. So you say it is lupus. That means we do not have any other clues even on EM, and then it is picked up by exo. Is it like that?
Exhaustocin positivity is not equivalent to lupus. It is seen in autoimmune conditions actually. So when you're seeing positivity for exhaustocin, it suggests that what you're seeing is an autoimmune related MN. So obviously in your electron microscopy, that you need to remember, in electron microscopy, we are evaluating a tiny tissue, right? We are just seeing one gloom or two gloom within the microscopy. Sometimes you may not get extraglomerular deposit. You might see only subepithelial deposit. You may not see TRI, which is seen in cases of lupus nephritis. So I think rather than going for a technique which is costlier, you have something which is lesser costlier, or the patient can afford for it. So I think we can go for these antigen-based methods rather than going to, because EM, it might help, it might not help in cases of your autoimmune related. It's not that in all the cases you can pick up the classical features of autoimmune related or the secondary features in EM. So it is good or wise to go by an antigen based or by immunohistochemical based diagnosis rather than going by EM and then coming to IHC.
Okay, thank you.
Thank
you so much.
Thank you so much, everyone. Thanks to all the speakers, the chairpersons, for sharing their valuable time and insights with all of us. This is the new session that we have added, kidney biopsy, and we will try to incorporate these sessions in future Win India Karnataka chapter webinars as well. And we found that our Win Karnataka nephropathologists were very enthusiastic when they got to know that we have women in nephrology group, and they were very supportive of our group. So it is, I'm really happy that you are encouraging our community, and you want to be a part of our community. That's really nice and encouraging for us also. And we're very happy, to be all inclusive and take this forward. Thank you so much, Dr. Gnanapriya and all the nephropathologists. We will make sure that we have such sessions in the future as well. Thank you so much, everyone.
Thank you, Dr. Maitri. Thank you for this wonderful opportunity.
Thank you, Maitri, for steering in the Win Karnataka session, an excellent session. I think you have got a good team, and in fact, the theme as well. You have some yardsticks on which you have chosen the topics as well. That's in fact appreciable, and very good work by the whole team of Karnataka. Thank you so much for joining, and enlightened to hear and delighted to hear that nephropathologists of women are keen to join us, and we're glad to share that we are just completing about 3 years of our establishment of in India in August 2024. So we have about 300 plus membership as well. You are at liberty to join us as an associate membership. So anyway, we'll share the details with you. Maitri will be keen to share the details and all. Thank you, everyone. Thank you for joining us, and see you all in Vinayakon, Thiruvananthapuram next month, August 3rd and 4th. Thank you so much. Thank you.
Thank you, ma'am, for leading this. Thank you, Manjusha, ma'am, for leading all of this. Thank you so much.
Thank you so much. Thank you.
Thank you.
Bye.
Thanks a lot,
Bye.
ma'am.
Bye.
Thank you.
Thank you so much.